All right, so we'll do these things today. So we're gonna have primarily as an EKG study sesh, EKG primarily, but we can still do other stuff, right? So we'll talk about treatments, meds for EKGs, and actually we'll kind of work on the EKG chart. We'll kind of put that at the top there, right? EKG chart, and we'll work on the meds and treatments, and also we'll look at fuzzy rhythms, things you're going to see in real life, right? Again, for your test, you're going to have very, very clear rhythm. It's very, very clear. You're going to assume it's a 6-second strip, or maybe I'll be zooming in on a specific complex. Like, well, that's not 6 seconds, because I want you to look at something. I want you to look at an interval or something to that effect, right? See, it's like, oh, that PR might be prolonged, or that QT might be prolonged, right? QRS is being prolonged. We don't really care about in your undergraduate RN degree, right? All you gotta know is QRS is prolonged. It's a bundle branch block. Right? Maybe MedSurg 3, you have to worry that if it's a new bundle branch block, it might be an MI, but that's beyond this, right? What we want to focus on is PR being prolonged and QTC being prolonged, right? Because if those are prolonged, it leads to complications, right? What complications are those? Blocks? Which one has blocks? You get AV blocks with a prolonged PR interval, right? And if it's a prolonged QT or QTC, what do you get? No, QRS, you get bundle branch block. Which kind of VTAC? Torsades, right? So let's add that to our list here, so in case we forget. So we just talk about our intervals here. I think we got a section for intervals, flavors, right? Interval support. There we go. All right, so PR interval, right? So how to measure normal length is what? Let's put it. Right, so sorry. Okay, so nope, so I don't like those ones. All right, so 0.12 to 20, right? Seconds. And then abnormalities, right? So prolonged leads to what? And leads to, I just changed to a arrow, right? Leads to what? AV blocks and junctionals and idioventricular, right? Whereas QT, right? And then just normal length is, so just put down QTC is better. It's not prefer, but it's required. It's complicated formula, right? But you don't have to know that, you don't have to calculate it for the test. Don't worry about that. All right, but normal length, whether it be QT or QTC, is less than 0.45, right? So 0.36, I think, to 0.45-ish. Okay. And you're gonna hold if greater than, hold meds if greater. It's usually 0.50, but yeah, if greater, if prolonged. Right, like they'll tolerate 0.50, right? But if it's more than 0.50, or I should say 0.45 to 0.50, but it's longer than 0.50, they're not, you should not give them at all, right? But same thing like beta block or PR intervals. If they're 0.20 and higher, you're concerned. But in real life, 0.24 is acceptable, right? That's not something I'm going to test you on. I just want you to realize, oh, it's greater than 0.20, I should hold this beta blocker, or I should hold another medication that prolongs it, right? We can put that here too, just meds that prolong, just to be complete, right? So it's med that's prolonged here too. Right, leads to torsades is the, I'm sure I can turn that off where it stops predicting the bullet point. Okay, leads to torsades, right, which is polymorphic VTAC, right? All right, does that make sense? Sorry, QT, Cs, and PR intervals, right? So what prolongs a PR interval? It's usually your ABCD meds, right? That's it, right? What prolongs your QT or your QTC? Nope.
Loperidol.
So one of the ABCD meds, which is amiodarone, right? And what else? Psych meds. Good. Antibiotics, antiemetics, right? So, these are the classes. I mean, if you don't know them, that's fine. But one of the antiemetics you do need to know for this test is one of your IV push meds. And one of the side effects of the IV push med is prolonged QTC, right? So which one's that? Just for Compazine is not used. That's an older med, but Reglan, again, we don't give brand names on the tests. Yes, metoclopramide, right? So yes, the metoclopramide is going to be it delays promotes gastric emptying, and it's also going to prolong your QTC. Okay, it just increases everything. All right, so then antibiotics. There's a few antibiotics that do it. So we'll talk about those more for when we talk about antibiotics, and those are going to be obviously a final question, right? So you know that antibiotics prolong QTC, certain ones do, not every single one. And therefore, you should know those ones for the final because in the final is cumulative, and we're going to talk about EKGs, right? Okay, but amiodarone sounds like a good test question now and for the final, really. And psych meds, and this isn't a psych course, so I may test you on that, like maybe like a SATA, I don't know, but like which ones these prolong QTC, okay? And antiemetics, that's fair game. Okay, which IV push med? Metoclopramide, right? The other ones really don't. Methylpenicillin doesn't, your pantoprazole doesn't, your famotidine does not, right? Your ceftriaxone, which is the antibiotic, does not. So the ones that do are just FY or your fluoroquinolones do. I think Q-fat was the mnemonic I gave with antibiotics. What does Q stand for? I don't even know. But anyways, I think because like fat QTC was the mnemonic I gave. Let's pull it up just so I can remember myself. Lectures, antibiotics, tubes, sepsis. So that's this for exam 2. It's like I don't want to learn about exam 2 yet. Just so I remember the mnemonic. So Q-fat. MFAT, that's what it was. Why can't I zoom in? What's going on? Zoom, zoom, zoom. I probably have this saved on my computer already, but you can see fluoroquinolones, aminoglycosides, and tetracyclines. So they're the ones that are going to fatten your QTC. Fluoroquinolones. What we say? Aminoglycosides and tetracyclines. Okay. All right. Anything else on those guys? So PR, QT are the most important ones that get prolonged, right? PDP interval, R to R interval, these are only concerning when what happens? Divorce. Very good. So concern. It's too big. All right. Anyways, you have concern when what happens? Different than R to R. That's a what? Okay. So it's the same thing with R to R. All right. Otherwise, it's the same. So same. Unless it isn't. That's helpful, right? So C abnormalities, right? So then R to R, what's the purpose of that? Right, measures heart rate. Usually I put down like a general things. So it's for measured heart rate. And the shortcut, right, is 300. All right, so that's your shortcut, right? You could measure it every single time, right? So measuring heart rate, it's the R to R divided by what? 60, right? I mean, yes, the 1500 method also takes 1500. I spelled all the math for you on the one slide that shows you how this all comes about. But yeah, 1500 method is also used if you took the small boxes, right? So a shortcut with big boxes, I should say, with big boxes is this, okay? But if you want to like measure specifically, it's R to R divided by 60, right? Because R to R is seconds, and you want to calculate what the beats per minute is, right? So every beat is this second, and then what's the beats per minute times six, that's being 1 beat per 60 minutes, right? So 60 seconds. Okay, so that's R to R over 60 is the technical formula, but you can measure it with this, that we don't need a calculator. That lets you know if you have tachyarrhythmias or bradyarrhythmias, right? It lets you distinguish if you have junctional rhythms or I should say idioventricular or accelerated idioventricular, because that cutoff's at 40, right? Whereas junctional is just like before, it's 60 or less or 60 or more. Okay, so abnormalities is, that's just tachy, brady. Okay, PR interval, QT, QRS, don't really worry about it, but what's the normal? Yeah, so like I said, some textbooks might do like 0.10 to 12 as an interventricular delay. We're not worried about that, right? So 0.12 is the cutoff, right? So if it's prolonged, that's a button branch block, right? Don't worry about left versus right. Right? You might have heard in clinical or some nurses say, oh, the one that you look at the bunny ears, that's how you tell the difference. It's not how you tell the difference, right? That doesn't tell you anything. Okay. It tells you if it's VTAC or versus SV2 of the Baronsey, but that's beyond RN scope. Or not RN scope, but beyond your ADN.
First semester the nurses taught me that.
No, the bunny ears don't make it. And we can talk about that at some point, but not for this for exam. Okay. It's very easy, but doesn't have to do with that. Okay. All right, so that's QRS, and then so that's good for intervals. So you wanted to look at medications next. You guys good with defibrillation? We can talk about that at some point.
Yeah. Pulses with lethal rhythm.
Okay. All right, some meds. So what meds are there? It should be non-DHP, good. And what's the last one? The jocks and so beta blockers. Also, it's another specific type. Which type? So man-babe. Okay. So it's just the ones that are in this mnemonic here. So metoprolol, atenolol, nadolol we don't give, but these and bisoprolol. So those are really the three you really give the most. But metoprolol is usually your first one you always think about. Okay. So indications, what are the indications for these?
Oh, yes. Yeah, that would be Brady. Wait, no.
That's your thing of side effects. Good. Good. So whereas the other ones are all atrial tachycardias, right? So this is atrial tachycardias, or I should say supraventricular tachycardias. Okay, so we can color code that too. All right, so then calcium channel blockers, same thing. Adenosine, what's that for? Not AFib, but only PSVT, which technically is yes an atrial tachycardia, but you wouldn't give it for like a flutter or AFib. Okay. All right. So mechanism of action will help you understand a few things, how it works. And then beta blockers you went over in detail and in MedSurg 1. So we're not going to really test you too much on the mechanism of action. We're really going to focus on understanding what rhythms in front of you and what you're going to do about it. Right. But then side effects, or some side effects of amiodarone. Good. So we could even put like all these medications is bradycardia, right? That's a side effect, right? Okay, what else? The AV block is not its primary thing it does. It might, but it's not what we're worried about.
For digoxin, yellow halos?
Hypotension. So let's actually do this. Let's go to all. This is all, right? So this is for, how do I indicate this is all? You should just do another row, but we'll just use the blue, right? So all of these cause bradycardia and hypotension. That's not something you want to know what's unique, because otherwise you're going to be like, you're flipping through your Davis drug guide now. It's like, what do I need to know that's different about these medications, right? Because I know these all cause this, all cause bradycardia and hypotension. So what's unique about amiodarone? Balance? No. The interval? No. QT, right? In the Paleolithic era of 20 minutes ago, right? So yeah, so QTC prolongation, which leads to torsades, right? Torsades. Also, you can, this would be more for MedSurg 3. It can cause thyroid, hypothyroid. It could cause lung damage too. All right, but what else for adenosine? Yeah. We can have this sensation of flushing because everything's vasodilating. So usually in parentheses, I'm going to put down, I want to put rationales. And I like to have rationales for everything, especially if I'm studying, because, when you're studying, you're like, I can't figure it out. What happened? Right? That's the idea with having the little rationale behind it. Okay. So, nursing considerations, explain to them, right? The nursing column should be things that are different from what's before, right? You're not going to sit in the nursing column write down that this is for atrial ventricular rhythms, or this is, I'm going to measure the QTC. It's like, yeah, I'm going to measure the QTC. So you want to make sure it's not over encumbered with information, that it just it's as fine tuned as possible, right? So like, yeah, check thyroid function, check that they are breathing okay 3 months while on the medication. That's going to be something that's going to be as a follow-up, right? But as far as adenosine, you're going to make sure that it's going to be, explain to them they can feel a flushing sensation, right? But there are certain things that are not explained here that you need to know about adenosine that are nursing considerations, which are what?
Monitor heart rate.
Monitor heart rate, yeah. Yeah, have crash cart. Yeah, hooked to the EKG is not going to help anybody, right? It's like, look, it's asystole. All right, have crash cart. Right? What else? What other things specific about adenosine you want to have? What did you want to consider? And 30 seconds, what? Fast half-life, right? Which is cool, right? If you know the half-lives of every medication, which is not required for clinical, except for the ones that where it is important, like this one, right? Because its half-life is about 6 to 8 seconds, right? So that means we need to do what? Right? So it needs to be pushed fast, right? Be a stopcock.
Do nurses push it? Doctors push it?
No, we push it. So it's perfect. There's a doctor helping out right there. Let's see. Perfect. All right, so it's pushed via stopcock, right? That's just the way it happens. All right, amiodarone, I mean, you could write down that it's given usually as a bolus first and then over 24 hours, but that's more for, you don't have to know dosing anytime in nursing school, right? The only exception is if for ACLS and MedSurg 3, right? There's absolutely no reason to know any kind of dose for any test or any other, maybe you have to know like low dose, high dose, like if it's like enoxaparin, is low dose is usually prophylaxis, high dose is for like an actual clot that they have. But other than that, there's no reason to know that, right? For med students in med school, they don't test on doses. Why are we making you do it? There's no reason. You learn that in clinical experience. You learn that in practice. Like, oh, 40 of protonics, cool, right? But that's not something I'm going to test you like the 40 or 80. Ooh, right? It's not something that's going to be. What am I assessing? When I just your ability to memorize, there's no reason to do that. Okay.
I don't know if it's a process. It's like, it'll give you like the order or something, and then it'll be like, what's wrong with this? And one thing I think is like, the dosage was wrong. I was like, I don't know the dosage.
No, it wasn't mine. Yeah, so it's a test on dosages is not a doesn't assess what is that assessing, right? For medications, yeah, even like even doctors' exams, and they have 3 board exams, right? They have 3 U.S. state board exam or U.S. board exams, and there is never a dose tested in one of those three exams, right? So, and that's as in 4 to 6 years of med school. They don't get tested on anything dose related. Okay. The exception though is ACLS. ACLS you do, and you learn that in MedSurg 3. And the spoiler, everything's 1, right? So it's 1 of epi, 1 of atropine, right? It is different. Adenosine and amio are the exceptions. And there's like 6 and 12, and amio is 150 and 300, but it's not something you have to worry about. Okay. All right, so that's dosages. So let's move on to beta blockers. So bradycardia hypotension. What else? Good. Masks hypoglycemia. What else? Might put that under nursing. That's not a side effect. It's like the side effect isn't masks. It's like, what does that mean?
Orthostasis, I guess that's hypotension, yeah. Sorry.
Careful with asthma patients.
Very good. So make careful with asthma. And why is that? So the rationale, this is MedSurg 1, but what's the rationale?
Bronchoconstriction.
So it bronchoconstricts, right? All those guys are taking bronchodilators, right? And if this medication is already there, bronchoconstrict, blocking the beta receptors, you can't bind to them with your albuterol or whatever. Okay. All right. And then prolonged PR interval, what else? That's pretty much it, right? So PR interval, and that's going to lead to bradyarrhythmias, blocks. All right, so then DHP calcium blockers, right? So usually I put a column on meds for examples. Let's put examples here, right? What are examples? Right, so those are the 2 examples, right? And what's going on here? So mechanism of action, we don't worry about too much. And then side effects. It's doing a page break. I'm not sure how to not view page breaks. There's a way to. There's, what's it called? It's pageless setup.
Oh, you just had it.
There's pageless. You have background color too. But if you print this, you have to then play with it. And why is it off to this? Let's get rid of this on the side.
Well, I have it on my computer. I'm not like saying I'm not gonna use it. It's not bad to not print something if you use it.
Yeah, as long as you-
But now it wants to, it's off-centered.
Thanks a lot, guys. Thanks a lot. Control Z. It's fine.
Yeah.
We'll fix it later. There's a way to get rid of the page break view so that it doesn't show where the page breaks. All right, so yeah, these guys, anything significant?
Not reflexive tachycardia.
So prolonged PR interval. Yeah,
Big.
flushing not so much. You could say like diltiazem has some mixed DHP activity, but we're not being tested on DHPs really at all this semester, right? That was all MedSurg 1. We talked about the antihypertensives, right? We will talk about some of their effects on like the lower esophageal sphincter, but other than that, there's not much other use for them. Okay, so prolonged PR interval, that's really it, right? And least blocks. And then we could also put it up here because it's kind of for both, right? OD. How do you treat the OD?
Big on.
Okay,
I mean, this probably doesn't really matter, but like, does it reverse it because it brings up the glucose, or is it just like a different mechanism?
no, it's a different mechanism.
Okay.
All right, so I'm trying to think of anything else for those, but you can review the slides to make sure that there's nothing else like critical that we're missing. All right, and then digoxin. So we'll put OD over here.
Got some immune fat.
Yep, digoxin immune fab. Okay. And then what about side effects? Long PR interval. It
Yellow
also has other
halos.
unique EKG findings, like a little scoop of the ST segment, but that's not something we'll worry about. But there are other toxicities. It's dig level, otherwise you get toxic, right? So it's normal dig level. You used to have to know all the numbers, but it's not so much anymore, 0.5 to 1.5 usually. Okay, but toxicity is,
This song.
no?
Yeah, we're saying what you do. Like,
So yeah, yellow halos, and what else? Nausea, vomiting, good. All right, so that's toxicity specifically to this guy, right? And that's why this guy was toxic. All right, start seeing yellow halos everywhere. Where's a good yellow halo? That looks pretty good.
Is that actually true, or is it just a tool you use?
That's true.
So,
He ate the foxglove. Let's look it up. Let's look. For epilepsy, they want to do it. Yeah, he had toxic digitalis effects. It's true.
does it cause
True story.
encephalopathy? Is that why he's all trouble?
Don't think so. He had epilepsy though. All right. So what else? That's those guys. So those are your meds for tachyarrhythmias, right? And then you only one of these for ventricular rhythms, and that's which one? Yeah, so ventricular tachycardia. Okay, and let's put that in red. All right, bradycardia meds. Good. What else?
Pacemaker.
Pacemaker, we could put somewhere on here. We should probably put a whole table for pacemakers.
I think that's.
Yes.
But how much of the information for like side effects and stuff from those meds are we gonna have to know for this exam? And if so, can you just somewhere post that last lecture so that we can kind of just do a refresh?
So the EKG lecture you're saying?
That's what-
Yeah. So for here under the YouTube thing, I put in your EKG folder. So I put the different parts right here. Right? So that's for if you want to recap and review. And a lot of this stuff, some of the stuff we're talking about right now are from those lectures, like adenosine and such, right? And the MedSurg 2 part, yeah, we're building on it, right? Okay, and then we're adding on blocks, junction rhythms, and pace rhythms. Okay. All right, so I'm not going to point you out, but I don't think you have to scroll down. Well, technically, yeah. Yes, it is page 2. Okay.
Yeah.
I made a landscape, so it would look pretty. All right, so where are we at? Atropine. Good. Epinephrine is a good bradycardia med. What else? Norepinephrine is more of a vasopressor, and that's not something to worry about for this semester. So that's MedSurg 3. Starts with an I. Yeah, DHP calcium channel blockers, not the non-DHP. They have a side effect of reflexive tachycardia, but that's not something you're going to give. You don't give medications for their side effects.
Sure.
No? Ipratropium does cause it's like we're gonna bronchodilate like a boss, and we're gonna make your heart rate go up. Starts with an I. Isoproterenol.
You're like, oh yeah, I was gonna say that.
All right, so atropine. What's the deal with atropine? What's it for? It's for bradycardias.
Uh,
It's for all, right? They're for bradycardia, right? And then as far as I mean, this is it's like sustained, right? If atropine doesn't work. If no pacer available. Ridgecrest. I'm kidding. All right, so they have like no pacer available, so they can't sustain it. So we have to give isoproterenol, right? So then we do pacers as the next fix for bradycardia, right? But atropine, what's the what was this? This is our mechanism of action. We're not too worried about that. This is it's a SNS. This is just a beta 1 agonist. This explains the side effects. That's why we learn mechanisms of action, so we can learn the side effects each time. We spent a lot of this time on this in MedSurg 1, so I'm not going to test too much on that. But as far as why this is, they're going to have tachycardia for this one. Well, tachycardia is going to be the side effect for all these, right? Okay. Atropine is a what? Penis blocker. All right. ENS, sorry. All right, so tachycardia is a side effect for all these guys. There's nothing else really unique about it. Atropine, you'll learn in MedSurg 3, you can only give 3 doses or 3 milligrams. Can't have toxicity. But other than that, there's nothing else.
No further, like, indication, it's just pretty much bradycardia.
Mhm. Yeah. And then there's specific nursing wise, not really. Like these are drip form. Keeps copying this. Three times. All right, and then epinephrine can be given push as an infusion, and this is given as an infusion.
Do we need to worry about atropine and epinephrine as like asthma and allergic reaction treatments or not really?
No, that's MedSurg 3. where you learn about, MedSurg 3 is all about the acute treatment of things, acute things in the hospital and the ER and the ICU. So, and these are things that end you up in the ICU when you have these things too, but you can also have these things on telemetry floor. So that's why we also get you exposed to it at this point. Okay. All right. You want to do pacers next, or you want to go fill up our EKG piece first? All right. So let's go to EKGs. All right. Are you good on sinus rhythms? I have not looked at this in a minute. Bradycardia is all dysrhythmias. Usually put, sinus rhythms, tachycardias.
For the causes, there's the electrolytes for tachy too, right? Like hypokalemia.
Yes, so tachycardia, and then fever, yes, SNS stimulation. I think a fever more is SNS also. We'll use there. So there's drugs and there's drugs. Right, so fever, yeah, infection, that's kind of more SNS. Low, is all kind of combined, isn't it? So hypoxia, which is low O2, this is low pH. And high CO2, low blood glucose, get pain, anxiety. Dehydration is pretty much low blood pressure. We can also put down fever here. Right? What else?
Hypernatremia and hypokalemia.
So lights. So hypernatremia is dehydration. Low K can put you at risk really for ectopy more than anything else. And then that can lead to tachycardia of some sort. Low K, low mag. All right, what else? So that's their causes of tachycardias, and then they're going to feel palpitations. That's every fast rhythm ever has palpitations. Or that's really all they're going to report until they get symptomatic, right? Then they get chest pain, shortness of breath, hypotension, confusion. Okay, and that's where you have to step in with the treatments, right? If symptomatic, right? Sinus tach is never treated directly. Underlying cause is fixed. Okay, so that's just a rule of thumb for any kind of sinus tachycardia. Atrial tachycardia is no. Well, yes, sinus tach is atrial tach, but if they have an AFib, a flutter, they have PSVT, you treat those, right? Yes, you treat the underlying rhythm too, but you actually we have medications for those. But for sinus tachycardia, we don't treat them. Okay, if it's like extremely tachycardic and you can't fix the underlying problem, maybe you might give these guys, right? Adenosine, no, that's not true. Let's fix this. Rarely, ABCD therapy. That makes sense, atrial tax. Okay, so we'll talk about atrials for next. All right, so what's the fix for anything EKG related? It's really should be for any EKG. Anything is for all dysrhythmias. What do you do? It's ABCs, right? So it's airway, right? So it's oxygen, right? At a bed up. What else? What's kind of breathing, right? And then what else? Let's put airway breathing. And then circulation. And what is that? Check blood pressure, right? Because that's going to tell you if someone's symptomatic or not. They could be feeling fine, but your blood pressure is 76 systolic. It's like that's now you've crossed the threshold into symptomatic, right? And we have to give you medications now. Okay, or we have to do interventions. Right? Which interventions were those?
Like nursing interventions or like med interventions?
Interventions. They're not nurse interventions. You're gonna grab the intervention.
Oh, okay. Huh?
Yeah. Right. May need crash cards. Let's just put that for shock. Right. Which is can be a like cardioversion or it can be a shock at 60 beats per minute, which is a pacer, right? So put down, so we'll put that there. All right, treatment is so symptoms, palpitations, fast. Otherwise, low cardiac output, right? That's symptomatic.
Could you write out cardiac output? Because I'm probably gonna forget what that means.
You think carbon monoxide?
Maybe honestly. Yeah.
Why is my carbon monoxide low?
Yeah. I wouldn't put it past me.
That's pretty-
Yeah.
Okay, treatment is specific, types, specific causes. It depends. All tachyarrhythmias are caused by the same thing, but bradycardias are not, are caused by different things. All right, so anything else on these guys? Clean this up still. So it's gonna be ABC therapy, right? Nothing else specific, right? But 12 lead, check BP, 12 lead notifies somebody. Let's put that up here. Okay, may need crash card for shock. All right, so that's tachycardia. That looks pretty good. Anything else we need to add to it? Or we need to add the drugs and drugs? What are the drugs that cause?
PHPs.
Good, atropine, epinephrine,
These are all steroids.
so breathing RX. Steroids don't. I mean, you could say isoproterenol, but these are these are the big ones that would cause a rise in heart rate, right? What about drugs?
Cocaine, meth, stimulants.
Okay, so cook meth. What's that?
Phentermine.
Better.
Phentermine.
It's a-
All right, so that looks pretty good. We'll look at the slides and see if there's anything else we're missing. That's big, but that's it for tachycardia, right?
Do we need to know decongestants?
Decongestants, they use phenylephrine. Phenylephrine has no effect on your heart rate. Well, technically, if your blood pressure it gets way too high, it's going to lower your heart rate if anything, with phenylephrine. All right, it's tachycardia, and these are some example strips here. You can do more example strips. Sinus rhythm is just sinus rhythm, right? You can put down other, make sure. What is normal sinus rhythm, right? So normal sinus rhythm is no abnormalities, right? Otherwise, you have a lot of kinds of flavors. You have sinus, you have PVCs, PACs, you could have, AV blocks, etc. Okay. All right. So then bradycardia is here. 1 to 60. Drugs, cholinergics. Okay. I'd rather, drugs, ischemia, that's what they're trying to get at. Drugs, ischemia, and electrolytes. IK, mag, and calcium. Sleeping is okay. sleeping athlete, vagus nerve stimulation. Okay. Hypothermia, all right. So ischemia would be like the example of NMI. It's also hypoxia. Okay. All right, so electrolytes, that's good. And then what about drugs? These make sense? Cholinergics, what's a cholinergic? Yeah, so not atropine.
Then.
Benztropine, that's for bladder stuff, right? Most of your psych meds have anticholinergic properties because they block histamine and such. This is for more like myasthenia gravis medications, right? They like your acetylcholinesterase inhibitors and such. You don't have to know that for, it's just, usually when I test you, I'm going to try to connect a concept, and myasthenia gravis was MedSurg 1. I'm not going to have you, I'm going to test you on that.
For psych, I know I remember this.
Benztropine is for your EPS side effects, right? All right, so beta blockers. That makes sense, right? It's all of them, whether it be man-babe or not man-babe, right? So SNS blockers. DIG, so it's basically let's just do ABCD drugs first. Right, so that takes care of that one, that one, that one, and that one. Okay, and you can see below if you want to look at your ABCD drugs. So cholinergics, it's not really, so just, I guess it's important to say not atropine, right? And then what over here? For sinus bradycardia, it's going to be the same stuff as above. Nausea, vomiting happens also with low cardiac output to the GI tract, right? So really low O2 is a symptom. Say so, see above. All right, and then treatment. So it's not, yeah, it's only when symptomatic. Could be a sleeping athlete. You wake them up, it's like, oh, you have atropine. It's like, whoa, what's going on? Okay, so, and we know blood pressure less than 90, right? Over here, less than 90. Oh. It's an important piece, right? Because we know the heart rate will be high or low, but the blood pressure less than 90, that's usually the line in the sand, whether we're going to get them treatment or not, right? That, and also if they have the chest pain, shortness of breath, or confusion. All right, so drugs, what kind of drugs do we do? The ones we talked about just now. We talked about atropine, dopamine. We didn't mention dopamine down here. Dopamine is not it's kind of fallen out of favor. That's probably why I don't think about it. Not being coy, it's actually binds to dopamine receptors, right? It's a precursor. Norepi, epi. All right, and then it's as a drip. Okay, go back to the dopamine back up here. So dopamine, isoproterenol, IV push, or dopamine, isoproterenol. All right, treat underlying cause. So that's good. The overdose here. And pacers. Pacers, it's if above ineffective. The two E's, yeah. All right, so what do you do to fix it? That's just the stuff above, right? Just copy and paste. The less information, the better, right? That's the idea. Don't try to duplicate unless it's, kind of the good reason why you duplicate is it's super important if you keep forgetting it. Okay. All right, those are sinus rhythms. Is this helpful or is this like, why watch this guy, type in a page, right? Okay. All right, good, good. All right, so those are your sinus rhythms, right? Again, if you want to hear it again, it's here under the the basics and sinus rhythms. We just covered part 1, 2, and 3. So you just save yourself 2 hours, right? Or if you listen to 2x speed, save yourself an hour.
Can't listen to you on 2x. You're like,
You're rapping right now.
Rapping. Third verse. All right, so atrial rhythms. Do you want to move on to atrial or do you want to skip atrial and do something else?
I mean, I'd like to do all of it.
Yeah.
Yeah.
So atrial rhythms, atrial fib. Yes, it's irregular. So this is describing the rhythm itself, right? Type description. It's more description. I don't know. We'll see how this works out. All right, so AFib, right? So we already said this. Atrial rhythms. AFib would be down here. This would be all atrial rhythms. I don't know. Let's see how this is organized. Let's just put all for this one. Insert. Why is that there? What is atrial fibrillation? Why did it get smaller? All right, so atrial fibrillation, how would you describe it? There are different types of it, but how would you describe features? Where's my bullet point here? Yeah, irregular is a huge deal, right? If you have an irregular rhythm, your knee-jerk reaction, AFib, right? But then if you see what would tell you maybe it's not AFib. So AFib has no P waves, right? If it's irregular and has P waves, then we're thinking of probably it could be PACs or sorry, PACs. Yeah, it could be PACs or it could be a second degree block, right? It's usually those are the options, right? So we can do that down here. Let's see how I could put that in chart form. Under P waves. EKG. We could do that too. Let's do this.
Save close.
Final maneuver or something.
That'd be like diabolical. Now to learn, you have to do it yourself.
So let's do P wave or say waves. EKG interpretation. Let's see if this works. Let's figure this out. All right, so you do P waves, right? Or let's do irregular rhythm, and then P waves, QRS complex. Likely rhythms, and you can say differentiation. We'll see if this works out. All right, so if it's irregular, you're thinking atrial fibrillation, right? You say atrial flutter sometimes. Let's put it down below. That's not always. All right, what else is irregular?
Degrees.
Good. Second degree AV blocks. What else is irregular? Good. So PV, so ectopy.
Is that what ectopy means? Just like, premature things? Okay.
Mm-hmm. Something where it doesn't belong, like an ectopic pregnancy. All right, so differentiation. Yeah, it happened early. It happened.
E waves.
All right, so differentiation is there P waves? Right? So let's go back over here. So P waves, sinus rhythms are likely, right? This isn't working out like I wanted to. All right, sinus rhythms, and then,
You could put like if E waves, like you could make like an algorithm.
yeah, it's an algorithm. It was more, I was thinking, but I was trying to get into chart form, but. All right, so sinus rhythms, and then QRS complexes. Let's put P waves present. Is there? Oh, so word this QRS complex.
BBC. It's not wildly big.
Wide, it could be bundle branch block, or it could be ventricular. Paste or bundle branch block. And usually I put the reason why for each one. So you can even hit enter and like put a little deal here, right? Ventricular because impulse not originating on fast pathways. Yeah, you can put idioventricular here too. Okay, so narrow, right? So narrow ones are what? So it's came from atria or atrial origin, right? And then you could say junctional are narrow QRS, right? So blocks, they could be too, but I don't know, I'll think about this one, if this is making sense or not. Let's go back to atrial rhythms. All right, so features irregular and no P waves, right? That's, but what they do have are fibrillatory waves. They're called F waves, right? So they have F waves present. So you look, so where's the P wave at? And you look closely, you see fibrillation. If there's no P waves and you look closely and it's a flat line, you're thinking junctional, right? Let's see if I can make this work still. So junctional is, that's a differentiation. Let's put absent. Absent irregular is regular. But this might work. All right, so let's put down P waves absent could be junctional, right? And you can put down fibrillatory, fibbin, then atrial fib, right? And then over here, say if you have absent, then it's a what? Absent QRS complexes. Basis is a good one to start with.
Oh, you're dropping. Okay, yeah.
So dropped, you got second degree AV block, right? All right, back up here. All right, so atrial rhythms. We got fibrillatory waves. Yeah, you have different types, ways to interpretation. You have slow ventricular response, you have controlled and rapid. And your goal with these guys is to, Did the font change? Yeah, changed. Goal of AFib is to control rate. That's really our one of the goal. The goal is not to convert them, it's just to control it. So the AFib RVR is dangerous, right? Get out of AFib RVR. Sorry, it's gonna bug me if it's not the same font. All right, so SVR, why are these asterisks? Oh, that's what it stands for. Okay, more AFib-y.
Maybe
Regular.
the picture, but.
Please not a 12 feet.
There's image options. Can't just rotate it like Word. It's-
2 minutes to find.
Me and my school cried because
It takes a long time.
That did it now for the wrong spot. Copy and paste.
I don't know how to use Control Z yet.
I'm trying to follow along to remember and I'm like, no, it's too fast.
No, yeah, there's no way to learn this.
All right, so slow ventricular response, controlled, or rapid ventricular response, right? Response. All right, types, you don't worry about this so much. All right, so then some reasons, right? Causes. So we're looking at here, right? Why does someone get AFib?
Oh, down there though.
So it's really two reasons. It's just structural. All right, that's like, MI. The structural is this stuff here. MI, CHF, age. So the cause why they're an AFib is because of this, which is SNS stuff.
So SNS causes all of the stuff above it.
Yeah, so SNS stimulation on a wonky part due to structural reasons or scarred is kind of the same thing. We already went over SNS stuff, so this should be unknown's a good reason, so that we don't know why, but it's usually something structural. Okay, so it's just an SNS stimulation, which is what again?
Blood pressure.
A low blood pressure, right? So we're talking about SNS stimulants, right? You got low oxygen, you got acidosis, you have, which is low pH, you have high CO2, you have low blood glucose, so it could be drugs too, right? So that all these things are causing increased SNS activity, and it's going to go down to a heart and make that heart beat faster. If the heart is healthy, it's sinus tachycardia. If it's unhealthy, if it has something structural, you're going to have a atrial fib. Okay, same thing for ventricular tachycardias. They all happen because of a abnormal heart. And it's usually in those situations due to ischemia, right? MI is on here too, but it's due to scarred. So when you talk about VTAC or ventricular tachycardias, it's because of a either hypoxic tissue that is very irritable and abnormal. Okay, all right, so is that good for causes? And then what is this here? Symptoms. So I kind of did that. All right, so symptoms. All right, so then the way to fix it, yes, it's a very popular arrhythmia, therefore it has a few more things involved. It has anticoagulants involved, right? And why are those involved? Good. So high risk of a stroke. Usually have a column just for complications, but this is like the only one that has complications. We're talking about arrhythmias. But the other ones have complications of death, right? Otherwise, this one's has complication of arrhythmias, right? Or sorry, of stroke. So CVA or PE are complications. Okay. So anticoagulants bring heart rate down with ABCD drugs. That's all the same. They're going to do ablation therapy and then direct cardioversion for symptomatic only. Good. Does that make sense? That's AFib. Right, so atrial flutter. Is just ditto. That's it, right? But to recognize it, so features, like you say. What are the features again? Has what we call it, has flutter waves, right? So it's a sawtooth appearance. Okay. Can be regular. Same stuff. It can be slow or fast. That's it. Ditto. There's no other differences. Right? Ditto if irregular. Because when it's irregular, then you start have the ability to form clots, right? And now the blood starts pooling. All right, so do you want an example strip, a flutter?
If you do a couple, some say look different.
This one looks, oops, don't want to click on it. Look for an irregular one. So it's harder to find irregular ones than it is regular ones. That's arguable. It's like AFib going into a flutter. And that's what happens in real life. They'll go back and forth. Like I wouldn't really classify that as flutter just yet. But like I said, there's some flutter ways right there. That's still regular. Let's put irregular. That's good. It has 3 and 4. All right, so let's put this one here. Thank you, Wikipedia. And copy it correctly. Okay. Let's, I think I forgot the other one. Shoot.
That's the one.
It's a little below it.
So why is it not pasting? There it is. Okay.
Yeah.
All right, so ventricular rhythms, or we forgot, these are H rhythms. We forgot one. What's the other one we forgot? It's called PSVT, right? Or paroxysmal supraventricular tachycardia. So you can put up here atrial rhythms. If it is fast, it is an SVT, technically. We say SVT, that could be sinus tachycardia also. Okay, but atrial fib and atrial flutter have normal variants, and they also have slow variants. but PSVT is always fast. And what do you know about PSVT? It's the same interventions, the same, what are some features of it at least?
150 usually.
Greater than 150, what else?
Regular.
Very good. No P waves, good. Or they might be retrograde, they might be buried and such. All right, they're an extension of junctional rhythms, right? No P waves. Also, what else?
Symptoms wise, or?
No. When you have fast rhythms, you can start thinking like VTAC. I don't know. Not sure that's helpful or not. All right, so then what is this? This is the causes, right? It's the same thing, right? Ditto. You have an abnormal heart for some reason, and the treatment is going to be good. Here's my. So we got two options. So you have farm and non-farm. And someone said adenosine. All right, what's the non-farm?
Modified Valsalva maneuver.
Someone. Yeah.
Work on a massage when? Yeah, it works. But they're facing ice, they're gonna, this cause vasovagal response.
We're not doing that.
No.
Yeah, we're not doing it. What's the one where you like turn them upside down? Oh,
It's called the Valsalva, right?
oh,
Works best, right? How's it go? Flip it, spin it, bop it. Happened. Oh,
oh no.
go my other window here.
Oh, add too fast. Click alt and then tab.
Oh, God, okay. When you were in school learning this stuff, did you make your study guides like this too?
Yeah, this is how I made it. Study guides, yeah.
Well, but I don't have one. You have it? That is.
Right, you saw the video, right? Of them flipping upside down. Okay. All right, so. Yep. Syringe, also, it's the exhale, it's closed glottis. How do you do that?
Oh, like you hold.
That you found the blow and that's how you explain it.
Mm-hmm. So bear down, right? Exhale, just closed glottis. All right, so carotid massage, what was the specifics about that?
Fingers on the neck or whatever.
So unilateral, right? Don't strangle them.
Oh, yeah.
What's that nursing student doing? Unilateral and age less than 45, right? Otherwise, you're going to cause a stroke, right? You're gonna dislodge their plaque buildup.
Feel your pulses.
All right, anything else unique about this one? So SVT symptoms are all the same. All tachyarrhythmia symptoms are the same. They have palpitations and they can be symptomatic, right? That's over here, yeah. So that's going to be defib. That's kind of an extension of this one, right? Direct current cardioversion. So defibrillation, I should say cardioversion. Right, if BP less than 90. Right, because adenosine is going to have what side effect? Yeah, it's like flushing, don't worry about, but it has hypotension as a side effect, right? The synchronous cardioversion is one of our last steps. All right, and specific things you would do is know the maneuvers. I don't know. Okay. Anything else unique about PSVT? Anything else you remember about it? Picture PSVT. A good one, but let's see another one. Let's go to the second page of Google. This is caused by calcium channel blockers. On Word, it's just there, but then you have to click 3 times to get to it. Was there another column and I missed it?
Page broke.
But it's even the page. No, maybe. All right, so that's it for atrial rhythms, right? Just the 3, flutter, fib, and there are other ones out there, but you don't have to know them. Like you mentioned, Wolf Parkinson White at the beginning. You have to worry about AV nodal branch tachycardias. You don't know about those either.
Good.
All right, so welcome back. So we'll start with this. We'll jump cut to here. All right, so that way we don't have the 15 minutes of dead time. All right, so pacers and pacer stuff. So this comes from the EKG Mastery book. All right, so I can share this with you too if you want to get more practice on these guys. But here's the example of a pacer spike. Let me see if I can get this over to where I can annotate as well. All right, you want me to save the annotations or no? Like share the scribbles? Oh, I guess you're gonna have the Zoom, so you can get screenshots also. I don't know. All right, so let me just make sure it's all good. So yeah, so you can see the pacer spikes here. Is that working? It's not showing for me either. There they are, pacer spikes, right? So you can see the pacer spikes, right? So those are what it indicated. So this is atrial pace or V pace? Is atrial, right? One way you can tell is that the QRS is narrow, right? And the other way you can tell is that the pacer spike is before the P wave. Okay. So let's clear all that. Oops. That didn't work. Let's use this one. All right, so this you can see is what? Is V-paced, right? You can see the pacer spikes are before the QRS, obviously, but there's no atrial activity because there is no atrial spike, but also this patient might have had a pacer placed because they had no atrial activity, right? They might have had a junctional rhythm, or they might have idioventricular rhythm. It's like, oh, shoot, you need a pacemaker, right? So they put in a pacemaker, right? They didn't put in an atrial pacemaker because they had no atrial activity. Why would you put that in? Because the whole idea about the pacemaker is it senses either atrial activity or ventricular activity, and it will either do nothing, right? It'll be inhibited, or it'll do everything, and it will contract, right? It'll do a capture, right? Those are the modes of pacing, where you have the first mode being what is it looking at, right? So what is it sensing? So, or what is it pacing, right? And then what is it sensing? And then what is it? What's my R's, right? What is it? What is this? What is its response, right? So here it is sensing it's going to pace the ventricles, and this really should be it should be CPARs or CPARs, right? But it's going to pace the ventricles when it is activated, or whatever is the controllers knows what to do with the information, and that information is assessed with the sense, right? It's sensing what's going on. So is it sensing QRS activity, or is it sensing atrial activity, or I should say ventricular activity or atrial activity, or is it sensing both, right? In this case, it's not sensing both because they probably needed it for a good reason. They needed it because they weren't having atrial activity, right? So it's sensing ventricular activity when it sees none, right? So, and none is kind of not subjective, but it's usually based on a rate, right? When it sees none below a rate of 60 or none below a rate of 40, right? Right, what should I say, above, right? So it sees someone's own intrinsic rate of like 85, there's no reason for it to kick in. But as soon as their rate starts falling below 50 or 40, then it will kick in, right? So when it senses ventricular activity, it's not going to go off. Or when it sees no ventricular activity, it will go off, right? And the other response is, what does it do? Does it inhibit the pacer, or does it just pace, right? And usually they're set in VVI modes where they are always sensing ventricular activity, and when the rate gets too low, then it will kick in, right? Another mode is like DDD, where it is completely doing pacing no matter what. And it won't pace when there is activity. When it sees activity that's too fast, it will actually be inhibited. All right, there's all kinds of fancier things you can do with pacers. All right, so this one is V-paced, right? So let's scroll up here. Let's get rid of this one to get more active. Okay, that didn't work. All right, so you can see this one has, what does this have? Still thinking, what's it doing?
Oh.
We have technical difficulties. All right, so here, get atrial spike and ventricular spike, right? And then this guy, what's going on there? It doesn't look right, right? So there's something abnormal. It is V-paced, that is true, right? So we do have V-paced activity, right? But we've lost something here, right? We've lost something there as well. So what is this? Failure to pace, failure to capture, or failure to sense? It's failure to, so it spoke, right? There's a pacer spike, right? So it paced. So it's not failure to pace. So yes, it was a voltage, but for some reason, it did not capture, right? So this is failure to capture. That doesn't contrast well, right? So it's failure to capture. And the reasons for that would be what? So it could be because of the pacer, or it could be because of the patient, right? There's something wrong with the patient. Patient could be like super hyperkalemic, right? You can set all the patient spikes in the world, but the membrane potential has been destroyed, and there's no way it can pace, right? It could be same thing with like meds. They could be on meds on board that are making it so that it's causing a prolonged QT where the refractory period is not they're not able to accept any kind of impulses, right? And then it could be the pacer's fault. So what could be the reason for the pacer fault? Could be the battery, right? The battery's not dead. The battery's dead, you wouldn't have a pacer spike, right? The battery's weak. The voltage is, let's say it's set at 820 millivolts, right? And it's only giving like 14, 10 even. So it's not able to get a full capture out of the patient's heart, right? Also, it could be dislodged, right? It could be, or not dislodged so much, that'd be failure to pace. It is a, could be on the way to be dislodged, but it could have scar tissue, right? There could be scar tissue over the pacer. Can you visualize what that looks like, right? So here's your right ventricle, and then you have a pacer that's sitting right there. And then if you have scar tissue that's growing, right? That impulse that normally goes through is going to get impaired. So it could be delivering 20 millivolts. The battery could be great, right? But it's not getting 20 millivolts on the other side. Okay, so that would be a failure to capture. But this easily could lead to failure to pace, right? Because what if this scar tissue gets enough to the point where it's not able to send any impulse through, right? Or the whole thing get dislodged. Okay. By the same token, you could have a fracture in the lead, right? You could have a fractional lead somewhere where impulse escapes, or some electricity that's going down here, some of it goes over here, right? So it's not a full impulse to the myocardium, and therefore doesn't capture completely. If the lead is completely fractured, completely severed, then you're going to have failure to pace, because none of it's going to make it down the wire to the ventricle. Right, so that's comparing failure to pace and failure to capture. Failure to sense is different. It doesn't really have to do with like a myocardial issue or a wire issue. It usually has to do with a sensitivity setting that's incorrect on the patient. Okay, all right, so it's clear all this. What about the next one down there? So we got a pacer spike doing its own thing, really, right? It looks pretty even, but it has no regard to what the patient's doing, right? So usually your sensitivity is, it's like a VVI mode. It senses ventricular activity here, and when it sees it, it's going to go ahead and do something, right? Is it going to inhibit the pacer, or is it going to stimulate the pacer? In this case, it would inhibit, but let's say it's going to be let's say what's trigger, VVT, right? Would be triggering the pace, to send a wave of depolarization. So if it senses ventricular activity, it's over sensing. It's like, oh, there's ventricular activity, there's ventricular activity, there's ventricular activity. Then that could be an abnormal pacer spikes where you don't expect them, right? This is failure to what? The sense, right? So what is this one here? So we have pacer spikes, right?
Is it captured? So they capture.
Failure to capture would mean you'd have a pacer spike and nothing following it, right? You would have a pacer spike, right? And then you'd have failure, you'd have a no beat afterwards.
Can have spikes in a strip and it can still be failure to pace.
No, I drew the pacer spikes right now.
Well, no, but there are spikes.
Yeah, these spikes are working great, aren't they?
Yeah. It's not always consistent.
Like, not
Got it, okay. I'm
Right.
saying it wrong, but
So yeah, so this one, the pacer spikes are working great, right?
Yeah.
So spike goes off and
Yeah.
you get a QRS. Spike goes off, we get a QRS, and then no spike. So what is that? Failure to pace. There's no pacing happening, right? And why is that? So here you have a generator here, right? And there's you have your heart over here, your right ventricle, and it could be just like I drew it. It could be dislodged, right? So it could be dislodged from there, right? Dislodged. Okay. So it'd be dislodged from the ventricle itself, right? Or it could be a complete fracture. Complete fracture. Okay, or the battery could be dead. Dead battery. All right, those are the common reasons. I gave you that table of the different ones. Are they anything we're missing from the table?
I'm honestly not familiar enough to know for sure, but.
This is what I'm talking about when I'm table mentioning. So exam 1, lectures. Unfortunately, it won't let me zoom in for some reason. But now it does. Okay. And let's go avert your eyes if you have epilepsy. Junctional rhythms, then we start talking about pacing after junctional rhythms, right? This table right here is what I'm talking about. But I can't use the hand tool. It's very finicky. Right, so you can see all these problems here. Right, so this is what I'm talking about here. There he goes. Okay, so we're just talking about what failure to pace, right? There's no pace or spike, right? And you're gonna have, it could be sensitivity, yeah, that could be it, that it's not sensitive at all, right? So it's not, the settings are incorrect where it's not sensing, it's not sensing any activity, but in that case it wasn't because there was, you had some pace spikes, right? But more commonly, it's a problem with the pacer. It's complete lead fracture. There's no contact. It's dislodged or there's a dead battery. Right? It's not the patient's fault. It's not because the patient is like super hyperkalemic every other beat. That's not a thing, right? So going back to this one. So what is our next one here? We got atrial spike there. Let's turn this back on. There we go. All right, so we have atrial paced. Why is that AV paced or V paced? So there's no spike here, right? So you would see a spike right before the QRS if it was V paced, or if it's AV paced, because there's such thing as AV paced. If you see a spike before the atria for the A and a spike before the ventricles for the V for AV paced. But when you have V paced rhythms, they always have wide complexes. There's no situation where you're V paced and have narrow complex. That's another clue. It's atrial paced. Right, the one right below it, you can see that is big wide QRS complex. There it goes. All right, so you can see that this complex is nice and big here. Okay, we got two pacer spikes and you have a wide QRS that is a AV paced, right? If it was V paced, you'd only have one pacer spike. So a test question on this, you would have be identified if it's failure to pace, failure to capture, failure to sense, right? I'm not gonna just give you what is this? This is V paced or AV paced, right? That's a knowledge level question, or you could argue that it's application because you have to analyze the rhythm, but it's just that's not the level of questions we're asking. We're asking you critical thinking questions where you see something and you have to analyze and interpret the information, right? Yeah. So you see this rhythm, what do you expect to be causing it, right? Or the treatment really is, for any kind of failure is to replace it, right?
For the one on the bottom, the B pace or AD pace one.
Yeah.
Would you do the 300 150 method, or would you multiply by 10?
So multiply by 10 can get you there, but 300 is more accurate for measuring the rate. But it's not. We're not going to decide if it's like tachycardia or not, right? So there's not V paced tachycardia or V paced bradycardia. It's just V paced or AV paced, right? Because the pacer should be doing what it's designed for, right? And that's a good point that I mentioned is that these patients can have exercise intolerance because of this, right? Because on the older models of pacers, they're set at a rate of 60. And if you're running a flight of stairs, that 60, it might not be enough cardiac output for that patient, right? But now they have patients that are very adaptable that will increase based when they're exercising.
So you're probably not gonna ask us to know a heart rate of a ventricular pace rhythm.
No.
Okay.
Yeah, so for interpretation purposes, like for test question purposes, it'd be more, this is the rhythm strip, and what are you gonna do about it? What are your next steps, right? What do you suspect might be going on? Okay, so do they have like hyperkalemia? And which one has hyperkalemia? Failure to capture, right? And let's erase all that. All right, so this one here, what is this? 8.7. V paste. And what is 8.8? AV paste. What is 8.9? It's V paste. And they can have PVCs with V paste. Okay. If they're symptomatic though, then that's a problem, right? But if they have no symptoms and they can have PVCs, that's perfectly fine. All right, what is this? Look at this combining old content, which is cool. Yeah, so you have the interval that's prolonged, right? But you see this one is that much and that one is that much, right? So there's only one AV block that has prolonged PR intervals or increasingly prolonged, right? And also we had a drop QRS. You can see this rhythm looks irregular, just kind of eyeballing it. So we know we have a second degree. It's a type 1 or type 2. Which one is it? A second degree type 1. The only way I tell the difference is that the second degree type 2, it looks like a third degree because it's about to get completely blocked, right? Like if you take a really, really bad second degree type 2 and you're blocking almost every beat, then it almost looks like a third degree. It's not a perfect mnemonic, but all right, so what is this one here? There's some ST elevation. I mean, it's a tacky, so you can light up right here, 300, 150. Not really. So it just looks like sinus rhythm, right? You have it's barely, I mean, you have to argue if that's like 0.19 of a PR interval. All right, so I wouldn't say it's a first degree. Yep. All right, so let's clear all that. Go down. So what is that one?
First degree.
All right, so why is it a first degree, not a second degree or a third degree? Yeah, so it's fine when that lines up nicely. This one kind of does. You can see it's bigger than a big box already, right? Erase nicely. There we go. All right, so you can see it's bigger than a big box, so it's more than 0.2 already, right? And then it's about, 2 boxes in, right? 3 boxes to the side there. So we got 3 plus 5 boxes, that's 8 boxes. So how big is that? 8 times 4 is 32, right? So it's about 0.32 on that QRS complex, or QRS, on that PR interval. So that is a second degree or first degree or third degree. It's a first degree, right? It's a first degree AV block. And again, that's a flavor of what? Sinus Brady, sinus TAC. What is this? You can see here, I got 300, 150, 100, 75, 60. So it's between 60 and 75 right there. So it's a sinus rhythm with a first degree AV block. Okay, what's this next one here? This is bigeminy. Yeah, just for that piece right there. Yeah, you could say that. And again, it's a flavor of a rhythm, right? This one's hard to say. It's also irregular. So you have what? 1, 2, 3, 4, 5, 6, 7, 8, 9. It's a rate of 90. Okay. So 9 times 10 in a 6-second strip is your number of complexes times 10 in a 6-second strip is going to be your rate. Right. And yes, it is bigeminy right there. It's not like the whole thing is bigeminy, but for this little period right there, yes, it's bigeminal. Okay. It's also multifocal. That's really bad. And it's from multiple different areas of the complex. And what else is concerning? So the PVC is like right on top of that T wave, right? So it's a high risk. It's getting really, really close to that T wave there. So that's called R on T phenomenon, which is the cause of torsades.
And once that happens, once it's just like a cascade kind of, and it just you go.
Yeah, they go into they go to a what's a run of it, and then they may just break or they don't break, right? It depends how sick their heart is. All right, what is 14 here? Which one is it, VFib or VTAC? So it's VFib, right? So why is it not VTAC? Because VFib, of course, right? Right, it's not uniform. So VTAC is, it's very, very uniform. And VTAC, that doesn't look regular, but VTAC is regular, right? VTAC is not irregular. VFib is very irregular, right? Even torsades technically is regular, right? Torsades is VTAC, but it gets smaller and gets bigger. Okay, so these are your polymorphic VTAC, and this is regular VTAC, right? That's really P stands for pulseless, so that's being put polymorphic or torsades. Okay, so that's those are your VTACs. And then you have this guy, which is VFib. What about down here? What is this one? What is it? A15?
What if yeah, if it's the 3 or more PVC, I think it would be
Right, these are like what becomes the P and the T because they're so many stations.
It's a third.
Good. Look at this. Look at this PR interval. That looks pretty ridiculous. It's 0.64. It's like a 0.64 PR interval. That's crazy, right? So this is looking like third degree. And how else do I confirm it? I can look to see is the P rate, march out, right? Is it different than the R rate? So here's a P wave, right? It's easier in real life. It looks like it's like this, right? So that's my P rate. You can see it's like on top of the T waves there. I used orange on red. That's not a great move. But then you can see this is very, very regular doing its own thing. And let's use a different color to pink, no green. Right? So you can see my P waves here. There's a P wave there, here, here, there. Right? So you can see how they are different. The blue and the green are different rates. The P to P and R to R intervals are different. That's how you know it's a third degree also. Right? It's also regular compared to like a second degree type 2 would be irregular. Does that make sense? Yeah, this is a little P wave on top of the T wave. Okay, so what is 16 up top? Yeah, you got some extra P waves. Whenever you have extra P waves, it's always flutter. There's no other condition where you have extra P waves, right, before the QRS. If you have another type of P wave inside the complex, but it's like PQRS, 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 but the P waves look different, that could be something. It could be like PACs, it could be some other variants that we don't have to know.
That's a variable block with irregular.
So we got 2 here, we got 2 here. I'm not seeing it quite variable. These look regular, right? It's just we have an irregular rhythm because of PVCs, not because of the A flutter. So this is A flutter with PVCs, right? And it's a unifocal PVC. It only comes from one area. It looks the same both times. The other one is multifocal because the PVCs look different, right? So it's A flutter with PVCs. Is it slow ventricular response? Is it controlled A flutter or is it rapid? Yeah, so we can go backwards on this one. This one looks like the best one here. Aligns with the QRS, right? So you get 300, 150, 100, 75. That's between 60 and 75 heart rate, right? All right, what's the one down here? Definitely some ST elevation. Anything else? This guy right here looks like it lines up right? So you can see how it's bigger than a big box there, right? So that's a prolonged PR interval. Good. So we got ST elevation. We have a first degree AV block. Anything else? Is this sinus rhythm or sinus brady?
Yeah, that's a, Liana made a good point. Why does it look irregular?
Good. Yeah, because it has PACs. Right? You could argue that it could be maybe PJCs, but so they're irregular. These are it's bigeminal PACs, bigeminal PBCs. So again, I wouldn't do this to you on a test or exam, but it has all kinds of fun.
So much.
So you can see these are little couplets here. This is the PAC. It's bigeminal PAC, right?
So is it actually ST elevation if there's PACs? Like,
Yeah, because this one has ST elevation also, right? Actually, a different color. Right, so it's sinus rhythm, 1, 2, 3, 4, 5, 6, 7, 8, 9. Yeah, so it's sinus rhythm. So sinus rhythm with bigeminal PACs and a first degree AV block with ST elevation. Right? You can't get a bundle branch in there. You got like 0.9, 0.09. Close. Okay, so that's a example putting everything together, right? All right, you want to keep going? This is 17 of
thank you.
a lot. There's 17 and then I think there's 50. 33, okay? All right, so I can share those with you if you want to. All right, so let's go back to our quick agenda. So just some pacer practice. And again, just fuzzy rhythm interpretations. So you will see things in real life that are not textbook. So you can see that like in this one that I share with you guys. This one's still not ready. That's crazy. All right, so over here, I had it open. Promise. So I share this with you as well, this cool EKGs, right? So this is editable, so you can edit it and add things to it if you want. Okay, these are from real life where there's different strips here, right? So you take them from clinicals, clinical worksheets, whatever, so that you can practice it. Okay. All right. Anything else you want to add to the discussion? Fuzzy rhythm interpretation. All right. All right. All good. Anything else you need to go over? So I did play around with this. I don't know if I play around with it more. It's called, like I loaded these, I made flashcards off the transcript. Like I made it like off the first YouTube video, the basics anatomy pharmacology. So I made like these quick flashcards. These are multiple choice questions. These are AI generated, so I have to go through them. I think it's like what, 30 questions or how many was it? 24 questions. So I have to like edit to make sure it makes sense, make sure there's nothing that is actually the correct answer. So there's like one for multiple choice questions, and I made one for with what are called closes, which are a type of next gen question, right? So they only made 30 questions. I'm sure it could make more, so I might have to poke it a little bit better. Then I have to edit it a little bit. So for instance, like you can study this. All right, the blank is located in the right atrium, initiates the might not have enough information. So that's why I'd have to edit it some more, right? So you can say, do I know this or not? And then it will sort it for you, right? Same thing with, I can share this too. So like I can share this, copy this, and you can put it, there's like an incognito where this is like anybody logging in, right? So this is what you would get. You get these flashcards here, right? And I would have to edit it to make it be useful. The blank indicates blank and can reveal details about patient conditions like blank. Again, I have to probably give you some more information for that. Again, this is AI driven, so it requires some human oversight in this current year, right? Monitoring whole medications is essential if the heart rate drops below 50 would be a good answer, right? Medications like blank and blank suppress the AV node, which slows the heart rate. So leaving AV nodes open. I probably wouldn't choose the amiodarone. I'd probably choose the calcium blocker to be a better option. So that's the idea. And it requires some editing. I mean, it's not too much heavy editing. But that's one of the ideas I had for making flashcards really quickly. That's what I was trying to do with this EKG thing, but it was taking forever to open. So for instance, let me see if I can do this real quick. Can close this. Ventricular chunk heart blocks, juncture rhythms, pacers. These first few pages. Delete this and delete all the recordings here. Clear. Let's go down here. So I'm just theoretically thinking this might work or might not work. We'll find out. Saving for examples of pace rhythms. So let's drag and drop this. It's not behaving. My computer's struggling with the streaming and the recording and everything else. Anyways, that's the idea, is that it would then, like, I was like testing out the GI, like the first few flashcards from GI. I just dropped the PowerPoint in there and it made 172 flashcards. So obviously you can limit it, right? But these flashcards, the nice thing is it's shareable. You can share the flashcard, so it has to be done once. It's still frozen. Yeah. Anyways, that's the idea. Okay. So if this is useful to people, for a majority of people, then I can put the work in to share it. But you just put a YouTube in there and it will start creating flashcards. For instance, let's just do this one. Let's do playlist here. Like cirrhosis next week, right? So let's copy this link. Create flashcards, you want multiple choice questions. And let's generate the questions. Let's try and do the other piece where it actually, because the other way it will actually take the it'll take the images. It'll give you like here, what's this? And then the backside will be the answer. Right. So there's 34 questions based on that YouTube video. For complication of cirrhosis. Nice. All right. So then it'll create quick questions for you. And of course, I have to vet them to make sure they're correct. But if that's something you guys want, because I paid for this service, so yeah. All right. Any other questions? All right. Thanks to you guys in the Zoom chat as well. Thank you.